Okay, everybody, thanks for being patient with our technology. I've done my introduction of Dr. Mestre. He's now, we've got him, so we're going to turn it over to him. So let's welcome Dr. Mestre. Thank you.
Good morning, everyone. My name is Tiago Mestre. I'm a neurologist at the hospital, and I'm gonna talk about, I think it's still a very contemporary issue of what's the use of cannabis and all its derivatives into for Parkinson's disease. Oh, I just need to be made co-host so I can share my presentation with the audience. Good. Zoom still has these little issues. Very good. So this is my presentation, and maybe some of you have already seen me presenting on this topic in a webinar promoted by Parkinson Canada a couple of years ago. So actually, it was very also informative for me of how much the field has advanced, and we're going to try and address this dichotomy between Parkinson's disease. Is cannabinoids or cannabis, a friend or actually something that we should avoid? So this is my overview for today's talk. And so let's start. So why cannabis, and why thinking that cannabis can have a role in human brain physiology or in diseases of the brain, such as Parkinson's disease? So I guess we could summarize and maybe tracking back, we can summarize my talk with this policy statement by Parkinson Canada. I think this has perhaps about 2 or 3 years, and really clearly, I think really summarizes very well what is the current state of science in terms of recommending marijuana, or I would say extending to even synthetic cannabinoids in Parkinson's disease. So still, we don't have a conclusive evidence that supports the use of marijuana in Parkinson's disease. There's a need for large, high-quality control studies to better understand the efficacy, and I would say also the safety of using marijuana medically for people with Parkinson's. And so ultimately, if the recommendation in terms of healthcare professionals and care teams across Canada really should somehow weigh risks and potential benefits, and try to do it for each individual patient. And so why cannabis? So when we think about the herbal source of cannabinoids, so we have the cannabis sativa. He has a significant amount of pharmacological active compounds, so that can have an effect in the brain. And most commonly, as some of you will know, we talk about THC and CBD. So perhaps the main lesson or take-home message how to distinguish the two, is that THC really has a greater psychotropic effect, and so it could have potentially a higher risk of side effects. And then the CBD, which tends to be less, so perhaps safer and with significant sedating, anti-vomiting, and painkiller properties. Also important, we know that actually our brain has a system of receptors in their cells that allows for these compounds to act in the brain, but also very relevant that the brain itself produces substances that act in the same receptors. And these are called endocannabinoids. And this is just some imaging studies show that where in the brain we have these receptors, and so where these substances act. And not to our dismay, they are located also in the basal ganglia. And the basal ganglia is one of the areas most affected in Parkinson's disease, especially with what relates to the motor symptoms of Parkinson's. And so what does this physiological system based on cannabinoid receptors, what's the role? And so I think this is an important slide because it summarizes some of perhaps the most consistent benefits, I would say, of cannabinoids, not only in Parkinson's disease, but across other conditions. So pain, so that's important. and we'll come back to that topic, to induce appetite, especially this is evidence more in people with cancer and undergoing chemotherapy, and antiemetic, but don't has perhaps other roles that likely the therapeutic implications are less well established. So temperature regulation, learning cognition, and motor coordination. I think we, as I said, I gave this talk maybe 2-3 years ago, and really now I think it's quite established, cannabis is in the life of many people that live with Parkinson's disease. And I guess can be in different forms. So you have the herbal cannabinoids, so smoked, vaporized cannabis, so edible forms. We also have the cannabis oil, which perhaps is a more controlled way of getting these substances. And typically you could have strictly THC, CBD, or with greater ratio of these two compounds, but also you can have mixed mixtures of both. And this has been used as medicinal cannabis. Then you have the synthetic forms, which has been approved by Health Canada for specific indications. And so you could hear these names of dronabinol, nabiximol, which is a spray, or a capsule of nebulone. And you see here the indication for which has been used. Again, inducing appetite, combating nausea, also in spasticities in patients with multiple sclerosis, which typically patients with Parkinson's really don't have spasticity, and then also the severe nausea. So again, these aspects of anorexia, so reduction of appetite. I would also have the pain and the severe nausea. And as you know, especially pain and nausea associated with, for example, taking levodopa can be common in Parkinson's disease. Also, as a word of caution, and this kind of really clearly with the hype, once cannabis became at least legal for medical use, is the flourishing of these cannabis clinics. And you'll see why the reason of this warning is that, in a way, the message, I have to say, it's not totally rigorous. I've had access of reports from these clinics, and clearly, I'll have to say that the level of evidence is very low. And usually when I see something like this medicine is good for ADHD, sleep disorders, inflammatory bowel disease, Alzheimer's disease, it's a panacea, and we have to be aware, and I'll show you why, that perhaps safeguarding some exceptions, for example, I guess aspirin or Tylenol, really the use of a medication across so many conditions, it's not that common, and should raise some big question marks. If you look at published data in peer-reviewed journals, there's been a growing literature on the real-life use of these substances. So this actually is a relatively new paper, and it was done in a huge project called Fox Insights in North America from Michael J. Fox Foundation, in which patients enroll online and provide some narratives and report of their lives with Parkinson's disease. And so in this study, there was 1,881 respondents, so quite a significant sample size. You see that different people were consuming different forms of cannabis, different frequencies of use. Interestingly, only 1/3 were using for more than 1 year. So there's some attrition, I would say, in the use of this cannabis, at least in this population. But also very important, and I always encourage my patients to do so, coming forward with discussion the use of cannabis with the doctor, and to my and so I'm happy to see that at least in this population, 70% really discuss this issue with their doctors. So interpreting these graphs, which has a lot of information, I would say that the main color you see is the yellow. The yellow is no change, so both for motor and non-motor symptoms in Parkinson's disease. But also if you look for the greens, which is some degree of improvement, you see tremor, dystonia, the stiffness of Parkinson's, muscle cramps, some dyskinesias. And then the part of non-motor, and you see some recurrent themes that I've shown already. So sleep, perhaps agitation, so the sedating aspects of these compounds, anxiety, depression, and pain. You see 3 items of pain: muscle bone pain, spine pain, and other pain, but also nausea. Okay. With any medication or any treatment our patients take, we also have to think about adverse events. And so in the same survey, when asked about worsening of symptoms that are related with Parkinson's, so that's what this table shows. So you see, these are symptoms that patients have from their Parkinson's, and the question was, do they get worse, or does the patient think that the symptoms got worse once taking cannabis? And so this is ordered from the most frequent worsening to the less frequent worsening. And you see things such as dry mouth, dizziness, issues with memory, increased appetite. Again, the effect on anorexia, but it can come with the potentially unhealthy effect of increased weight, daytime sleepiness, balance problems, ability to perform ADLs more complicated, and even hallucinations. So really this balance of what are potential benefits patients experience versus the side effects. This is just an illustration. It was published in the Canadian Medical Journal, and this was from the Toronto group at Toronto Western Hospital. And this might have 3 to 4 years where someone with Parkinson's disease start taking Nebulone, so a synthetic cannabinoid for foot dystonia, that was painful, and really got into a severe psychosis that actually was maintained even after discontinuing Nebulone. So required admission to the hospital. Of course, patient was taking other medications that could further lengthen these induced psychosis, such as the dopamine agonist, the Mirapaxol, Pramipexole, but really calls to the, how careful we need to be when considering the potential use of this medication, or when we ask our patient, should I take it and what should I take it? Okay. And so going from patients to physicians, what we see is that, so in this survey done to centers of excellence in North America, so the National Parkinson's Foundation, so healthcare providers were asked, similar to what you see in the previous study of what potential benefits do you see in your clinical practice? And so you see that the greens are the no effect in this case. And so you can see dyskinesias, depression, urinary symptoms, bradykinesia, so the slowness of the Parkinson's. And then if you see the blues, which are the improvements, again, interesting recurrent topics. So I would argue some known motor symptoms, appetite, pain, nausea, anxiety. In some cases, tremor, almost like a 50-50 in comparison with the no effect. When we talk about the reds, which is the worsening, so fatigue, motivation or apathy, sleepiness during the day, balance, forgetfulness, and hallucination. So again, that concern about confusion, it's measured, especially with people that are older and have Parkinson's disease for a longer period of time. And so this is the real life use, I would say. And of course, it can change from country to country. And so the next section in my talk will be, what is the evidence? So what are the data generated by clinical studies that informs us physicians of what we should recommend or not, and what is the cautionary recommendations we need to give considering potential side effects. And I use this section also to try to illustrate how drugs such as levodopa or other drugs that we use for Parkinson's disease, how do they come to be approved by Health Canada, and we come to prescribe them. And so this leads to how we develop drugs. And so it's what I call evidence-based assessment. And the first concern is this drug safe or tolerable enough to allow first for further studies and ultimately to be approved. And so this is kind of a diagram that shows a couple of ideas. So it's a time-consuming process that they can take 10 years or more. between trying to scan for potential drugs of interest, then testing in animals, the preclinical phase, then the clinical trials. There's different phases, and the confirmatory phase, the phase 3, that usually leads to companies to submit their data to Parkinson to FDA or Health Canada, and eventually get approval. And these drugs also ultimately are also monitored even once they start being prescribed by doctors. So there's really a huge attrition, so usual funnel in which, for example, 10,000 compounds that are initially listed leads to one compound. Okay, so has this be done for cannabis in Parkinson's disease? I don't believe so. But ultimately, it's also important that these aspects leads to these relevant scientific evidence. And ultimately, there's our clinical judgment, but also the patient's values and preferences. And that leads to a synthesis that we call evidence-based medicine that I'm truly supportive. And so what is the evidence? I bring this quite classical picture of a parachute. And clearly for a parachute, I think everyone would agree that we don't need to go and have clinical trials. The impact of someone launching from a plane without a parachute, I think it's clear for everyone that will be tragic. But of course, that's not the case of cannabis. And so what's the evidence in Parkinson's disease? So I try to update the evidence both for motor and non-motor symptoms in Parkinson's disease. For motor Parkinson's disease, I found these 4 studies. And what are the messages that I would like you to take from this slide? So very few studies looking at different formulations. So there's a heterogeneity in the type of compounds that are being tested. So the conclusions that can be taken from this evidence becomes a little bit complex to digest and recommend to patients. I don't want this to be too technical, but in terms of the study design, so in terms of the design of the studies that are used to generate this evidence, it's important to have in mind that the standard or the paradigm is this randomized, controlled with placebo. So the sugar pill or everything, or pill that looks, smells, and tastes like the true drug, but patients also do not, and also physicians do not know if they're taking patients are taking the sugar pill or the active compound. So 3 out of the 4 did have that high quality study design. One was open label and not controlled placebo. So basically patients were given a cannabis formulation and were just monitored for side effects and benefit. And then 2 were crossover. So patients had both the experience of having placebo or the active treatment in the same study. What were the features that were assessed in this study? So dyskinesias, so in 2 studies, dyskinesias, and more generally some motor and non-motor aspects of the Parkinson's. And ultimately, the results were either negative, with some concerns for side effects. Okay. So these studies actually and others led to panels both in the US and internationally at the level of the Movement Disorder Society, which is the International Society of People that deal with Parkinson's, to consider that these drugs are either investigational and are not effective. For example, in this case, are not effective for levodopa-induced dyskinesias, for the dystonia or the posturing of people with Parkinson's, especially in their off times. And so this statement of the recent benefit should be weighed carefully, as I think I already highlighted in some of the slides I presented today, and kind of mimicking the policy statement by Parkinson Canada. And this was the same in this Movement Disorder Society. So they really call for high quality randomized control studies to evaluate efficacy and, just as important, the safety in Parkinson's disease. Now, what are the new things we know about non-motor Parkinson's? So I have to say there's been, in the last couple of years, there's been 2 studies at least that have been quite well designed and with a clear hypothesis. So one tried to test the cannabidiol, so a synthetic cannabis, for a sleep problem patients with Parkinson's can have, and actually can appear before the onset of the clinical the motor features of Parkinson's. So it's the RBD, or REM sleep behavior disorder. And so these patients were randomized to either cannabidiol, CBD, or placebo, and they looked at the improvement or the recurrence of RBD. So they didn't find an improvement or a change between placebo and CBD. There was a transient improvement in the satisfaction regarding sleep in the short term. Okay, the meaning of that is difficult to interpret because it was transient. Again, could there have been this placebo effect? We don't know. Another study, which is quite interesting. So they looked at patients with significant anxiety or pain. So important non-motor aspects of Parkinson's. And they first enrolled 47 patients. And then they looked at people that had responded to the medication. Again, this is Nabilon. And so for the responder, so it goes from 47 to 38. They then did what we call, in 50% they gave placebo, and in 50% they were kept on the drug without knowing that. Okay. And what did they found? They found that there was, in the placebo group, there was worsening of a scale that captures anxiety, pain, although other items, they really don't break down to the items, but potentially could be related with anxiety or pain, and potentially also worsening of motor symptoms in the placebo group. Of course, this raises a question, but does not confirm it, that for people that have responded to Nabilone and have anxiety or pain, potentially being on that medication could be of benefit. But in this carefully weighing between benefits and side effects, I also brought the data on adverse events. And so there's a significant amount of patients with fatigue, so increased fatigue, which is important and sometimes difficult to treat symptom in Parkinson's disease, dizziness, daytime sleepiness, upper respiratory tract infection. I would not think it's related with the use, I have to say, dry mouth we've seen, and others, so confusion, disorientation, even falls. Okay. And so let's talk about cannabis for pain in Parkinson's disease. And so there's also some dedicated studies looking at pain. And I think a main reason for that, as I've shown before, is that perhaps pain is one of the most consistent benefits, therapeutic benefits we know cannabis can be used for in medicine in general. And so what has been shown in Parkinson's? So I found these couple of studies, relatively small, in which they are not controlled or blinded. So patients are openly and knowingly getting cannabis, and the investigators will look how they are in terms of pain before and after taking it. Interestingly, these 2 studies look at the short-term benefits, so 30 minutes after taking the compound, and one of the studies looks at 10 weeks, so 2.5 months. And so they did report some improvement, but again, this doesn't, for example, control for the placebo effect that we know it's quite prevalent in Parkinson's disease. So the expectation of a benefit, and we can argue that patients going on these trials are expecting some benefit, are interested about these compounds and their potential benefits for Parkinson's disease. With that in mind, our group in Ottawa, together with my dear colleague, Dr. Fox, in Toronto Western, we were kindly supported by Parkinson's Canada to explore more the tolerability and safety of cannabis oil for pain in Parkinson's disease. So having in mind that THC might have more significant side effects, we proposed to involve 15 patients with Parkinson's and bothersome pain that were given different formulations of cannabis oil with different ratios of CBD and THC. And so this study was I have to say was kind of paralleling the wave of use of cannabis in Canadian society and also our patients, and has taken some challenges, not only the COVID pandemic, but one of the exclusion criteria was these patients shouldn't have had the previous exposure to this medication. And so, as you can imagine, it kind of curtailed our target recruitments. But we do have results currently, and this is from 8 patients, so half of the target recruitment. And we don't, because of it's a relatively small sample size, we don't have safety data per formulation in different groups. So this is the overall safety. And so by now you see recurrent topics. So first, 7 out of the 8 participants did have adverse events, but none were serious. And again, this is this study was very careful as patients were titrated till they had some side effect. So in a way, it's expected for patients to have side effects because that will be the maximum tolerated dose. But then it's also interesting to see if are there serious adverse events. So that means are the patients having significant symptoms that lead to hospitalization, so being admitted to the hospital, or for example, dying, and that these are serious things that we want to avoid with any medication. And then we look at other side effects. So perhaps more common, drowsiness and sedated state, dizziness or lightheadedness. And so ultimately, what are my take-home messages in today's presentation? So one is that cannabis definitely is now legal in Canadian society, and people with Parkinson's use it. Unfortunately, till now, there's no good quality evidence to support the use of cannabis in Parkinson's disease. I think, and I'm glad, I think I found myself being part of trying to play a small role in this aspect of how can we promote in society the science behind the discovery of better and safer treatments, and ultimately, as I showed in a slide, that hopefully that can inform how we incorporate that into the clinical judgment of physicians, but also in patients' values and preferences, and ultimately make a safe recommendation to our patients. And I think ultimately we're still in need of clinical trials to assess the risks and efficacy in Parkinson's disease for cannabis, as well as any other intervention. One last message, and this is I'm plugging for a project I'm involved, so that's my disclosure. It's called iCare PD. So this is a consortium that tries to, this is led by Canada and also with European partners. We're trying to provide a formula to better deliver care for people with Parkinson's that makes the best use of community resources through care integration, tries to empower patients through self-management support for self-care. And I think that's a very powerful tool and concept, because for many people with Parkinson's, their contact with their Parkinson's clinic and their Parkinson's doctor might be a few hours in the year. When I say that, I'm thinking about the clinical visits. And so how can we empower patients through knowledge and education for self-care in all the other hours of the year? And also, can technology help with that? So we're having an annual meeting. It's in Europe, but we do have a keynote speaker on the 20th of May. Many of you have heard of her. Is Dr. Sonia Matur. She's a patient. She's a physician, also a family doctor, and a strong patient advocate. So, for example, she has a site called the Unshakable MD, and she's part, for example, as co-chair of Michael J. Fox Patient Council. So feel free to contact me at tmestre@toh.ca. I recognize that the link to register, if you want for a Zoom for the virtual meeting, is quite complex. But if you send us an email, I'm more than glad to share that. So this will be on the 20th of May from 12:30 to 1:30 Canadian time, Atlantic time. Okay. And with that, I'd like to thank you for your time, and I hope it was informative and helpful to try to address this aspect of is it a friend or foe for Parkinson's disease cannabinoids? I think in a way it's the analogy of Dr. Jekyll and Mr. Hyde, and so ultimately I think potentially there will be some indications where cannabis might have a role. And I think now about potential pain, the sleep part, but still it has to be clear in my mind, how should I counsel patients in terms of the risks? And that for me remains a big barrier for a more informed recommendation. And now I'm open to any questions you might have. Thank you again.
Thank you so much, Dr. Mestre. Do we have anybody with any questions? Just raise your hand. We've got some mics. Mark, you've got a question? Go ahead.
I always get to start it off. So, Dr. Mestre, I've got a couple questions actually, but one of them has come from some of our support groups in asking that if there's any evidence of the use of regulated cannabinoids versus unregulated, i.e. what you might buy off the street versus what you're buying in a government-regulated store. If there's any difference between the effectiveness or the usage of them, or any warnings about that.
Yeah, so I didn't come across, with any clear comparisons of that. But I mean, the way I would approach that question is that, typically, an unregulated, sale of these compounds, you might generate questions and concerns about how what is actually in what is being sold versus a regulated use that perhaps is more controlled, and so there's a greater insight of actually what is being sold. And I would also extend that to if you have a synthetic cannabinoids, or for example, the case of oil, where there's a clear extraction and you really have a better knowledge of what is being sold. For example, I showed the cannabis oil, there's a clear ratio of one versus the other, and clear THC and CBD seem to be the most relevant compounds. So again, if I had to choose, and with this level of evidence, I would favor more regulated sale or synthetic versus a compound where there's a clear indication of what that compound that's being sold contains. But it's just like almost a good clinical practice recommendation, like a good common sense recommendation.
Wonderful. Thank you so much. Any other questions?
They're quiet. They're going to keep asking, making
Yeah.
me ask them.
Yeah, go ahead, Mark.
Okay, second question is, and I think I know the answer being, as you're a neurologist, but do you have a recommendation as to who a PD patient should talk to about cannabinoid usage in terms of a GP, a neurologist, or your local pharmacist?
I mean, I think, I wouldn't think he has to be only a neurologist. I think it's, for this topic, it would be nice. I recommend, you could have second opinions. And so you get some information from your family doctor. I'm quite open in discussing this topic with my patients. For the reasons I stated, I don't recommend it. And at this point, I don't feel comfortable in prescribing it. That might change in the future when I think there's more evidence. So I think, talking openly with the different, members of who are of what I say extended care team, I would recommend that. And ultimately, patients have the autonomy to make their own decisions. I think it's the role of physicians and pharmacists to provide, I guess, their interpretation and share the data and the evidence that is available. And that will be our role.
Wonderful, thank you.
And perhaps I'll just tell I've had situations where, again, I said at this point I don't feel comfortable in prescribing it, but I'm very open to my patients. I set out what are potential advantages, but knowing what are the risks at stake. And I do recommend, and I suggest, because of my also my of research interest that, and I would ask patients, what has cannabis done for you if they go on having this medication? And I have mixed responses, to be honest. And I think it's increasing our knowledge of its use, because again, we know it's being used. So we should learn more about it if it's even at the level of clinical practice, and then try to incorporate with the growing evidence that is being generated from a research perspective in clinical trials.
Wonderful. Anyone in the audience have any questions? I know Mark has a couple more if...
Well, Mark doesn't want to answer, but he doesn't have to. Okay, it's back to me still, I guess. You guys are killing me, by the way. Is there an ideal time, Dr. Mestre, for a PD patient to consider using cannabinoids in terms of too early in the process versus too late?
Mm-hmm. That's a very interesting question, and I think it comes to mind two ideas. So, first is why, what indication for which symptom is the patient considering the use of cannabis? And so, if we try to answer that question, there are symptoms that are more common early in the disease versus later on. So there's that element. So depends on what you're considering for. And I think, a team that I think it's more consistent, it seems that the evidence that is, I think, more outside Parkinson's disease, what has been more consistent, things like nausea, inducing appetite, potential helping with sleep because of sedating properties. So that's one element. And so if those symptoms are more prominent in a patient, potentially that could lead to some discussion of benefits and risks. But clearly, I think looking at the effects on psychosis, confusion, which can be quite worrisome, as I illustrated in that case report of a patient followed up at Toronto Western, I would think, as more advanced, I would be more concerned, right? Because as patients get older and they are frailer, and the Parkinson's also is longer, whereas there's a greater risk of cognitive impairment and confusion, I think that would be the group where I'll be even more concerned about using these compounds.
Wonderful. So we're going to take one last question before we wrap it up. Mark, there's a gentleman here.
Yes.
All right, doctor. My question is with balance. My biggest problem is balance. And I've lost complete confidence now, be able to walk without a walker. What can you recommend for that?
So I think following the topic of if I understood completely the question, so having balance problems. So balance problems can be a significant issue, more so as the disease progresses. And I think the main reason why that is the case is that in some patients, but not all, and perhaps that's your case, where the balance no longer responds to dopaminergic medication, so levodopa or agents, it really becomes a big problem. And so I would not, how should I formulate it? I would not consider it, come to my mind is, with a big question mark, can cannabis have a role? It seems by the data we have, definitely would not be a good choice, because again, it can increase confusion, it can increase sleepiness. So if that puts all together, reduce the attention that you need to have when you have balance problems. So I generally recommend preventative measures. So being very open in terms of using gait aids, perhaps earlier on Nordic poles, walker, eventually, and that's usually it can be a challenging decision to take of using a wheelchair, but prevention, and first and foremost, prevention of falls, that's my main clinical concern. Having usually with community services to assess people's homes to reduce the risk of falls, that is done through the lean most commonly, either PT, OT, and making recommendations. Usually they don't make any changes, they just make recommendations of reducing the risk of falls. Potential exercise, we recommend exercise at any stage of Parkinson's, but these will be my general recommendations. And definitely it's, in terms of more drug-based treatment, it's a significant gap in Parkinson's disease, especially later on, and when medication, the regular Parkinson's medication no longer works for those symptoms.
Wonderful. Thank you so much. So thank you, Dr. Mestre, on behalf of all those in attendance and watching virtually. I know your research is being followed very closely by both our PD patients and our healthcare professionals alike. If you still have any questions or questions you come up with later on, you can direct those to our office, info@psso.ca, and we can forward them on to Dr. Mestre and maybe get them answered and back to you. So thank you so much.